Hello, good evening, everybody. Please, I'm not hearing anything. I don't know if the lecture have started though. I can't even hear a word.
Everybody here can hear you because the class is muted. Everybody is hearing you. Hold on, man. The lecturer is trying to share his slides, so hold on for him.
Sáàfù ọkùnrin arọ́ṣù ní spiriti agogo ní ṣe kí wọn ní kọtí èmi ò pé ṣe ti bàbá yẹn ayé ìyá máa lọ kúnlé ara lọ máa wá kọtí àti àwọn ọmọ tó dẹ̀ nígbà ní sílá ọ̀dọ́ tó ọmọ òkú pẹ́pẹ́
Okay. Can you see my screen?
Yes, sir.
Okay, thank you. So welcome. Good evening, all.
Good evening, sir.
My name is Bernard Solomon. I'm going to be your lecturer for medical cytology and cytotechnics. So I will take the lecture today, tomorrow, as I understand that the university wants our lecture to end this week. So for today, I will take the first lecture, then tomorrow I will round up your lectures for the semester. So medical cytology and cytotechnics. Objectives of today's lecture. At the end of this lecture, students should be able to understand the basic concept of patient preparation, sample collection, handling in gynecological and non-gynecological samples, should be able to understand the difference between the squamo-columnar junction and the transformation zone, list and explain common staining techniques for gynecological and non-gynecological cytology, justify and explain the liquid-based cytology method of psychological preparation. Now, students should be able to list and explain cell block preparation for hypocellular samples. And should understand criteria for reporting malignancy, infection, and inflammation in cytological smears. Then should be able to list staining methods for bio-body determination and its clinical application. So as soon as you observe that my screen is not showing, please kindly alert me so that I can readjust from my end. I will be guided by this outline today. It is important that both patients and the laboratory take adequate preparations for cytology sample collection and processing in the laboratory. And aside from ensuring that the right sample is collected for the right screening, keeping the specimen well is very, very important. I mean, while transporting it is very, very important that it be preserved before it gets to the laboratory. Patient must be prepared to obey certain conditions before the sample is taken so that quality smear can be taken and processed. If anything is wrong at that level, then there's nothing one can really do to get quality results. So we are going to look at that today at this lecture. So I'm going to take them one step after the other. So basic concepts in sample preparation and collection. We look at patient preparation, fixation, request form documentation, specimen adequacy, and validation of smear quality. All these are very, very important and they are basic concepts. So what will you tell the patient to do? We are going to look at it. And how should you handle the specimen? What should you use to fix the specimen? And of course, how do you ensure that everything you did is documented? And of course, the satisfaction in having an adequate specimen or sample. And how do we get the best from it? I mean, on optimizing what we have. Okay, so specimen handling for gynecological and non-gynecological samples. The first is the pre-analytic. What happened before the sample is even collected? I call that rational choice for testing. There must be rational choice for testing. The test must be fit for purpose. Is it going to be for screening? If it is for screening, then the objective for screening is to detect malignancy. Is it going to be for forensic purpose? Is it going to be for research? So there must be rationale behind the request for cytological investigation. Once that turn is rightly done, we can talk about the pre-analytic step, collecting the specimen with the right tools, ensuring that it is fixed immediately, then documented and transported to the laboratory. After this is done, then the analytical stage will follow the protocols in the laboratory, receiving them, the reception, then doing the macroscopy, staining, validation, screening, and of course, the eventual diagnosis. And this is followed by the post-analytic reporting, typing, or transcription of results. After this, the report will be dispatched. Now, it doesn't end there, because even after you have made the diagnosis and dispatched the report, we must ensure that the report gets to the right individual who needs it, the right patient. So if that area is not taken care of, all efforts may eventually be misdirected, be in vain. I mean, now having the right result for the wrong patient because it wasn't delivered to the right place. So that should be taken care of. And of course, the post analytic report filing, once everything is done, we have to keep the records permanently, archive it or cloud it if you are using the technological devices. Total quality smear. How do you ensure that total quality smear is collected? Smear collected must be of high quality. Samples should not be collected during menstruation. This is how you prepare your patient. You must let the patient know that she should have completed her menstrual cycle before coming for the test. The patient should be told too that there shouldn't be vaginal douching. No extraneous substances should be used on the vagina. And of course, there should be abstinence from sex. And no medicine should be applied to the vagina 24 hours before sample collection. This is a very good way of preparing the patient. More, sample must be collected at both the transformation zone and squamous-columnar junction. I'm going to explain this further later so that you have better understanding. Cervical sample must contain both ectocervical and endocervical components to fulfill adequacy of sample. Sample should be adequate. And to make it adequate, we must have components of the ectocervix and components of the endocervix. Perhaps we should have the squamous cells and the glandular cells. Sample must be properly fixed in 95% alcohol. That's the choice fixity for cytological investigation. And it should be well preserved at 4 degrees Celsius. If for whatever reason the sample can't get to the laboratory, the same day it should be preserved at 4 degrees Celsius. After that, could be transported to the laboratory, keeping it in the right condition when the distance is far. Then samples should be well labeled, and the request form should be completely filled with the patient details and the physician details. We'll continue on having the total quality smear because this is very, very important. This is the foundation. History and clinical details of patient must be included for good interpretation. Age, sex, last menstrual period, information on postnatal situation, postmenopausal condition, pregnancy, hormone therapy, IUD, or whatever information is necessary concerning that patient. It should be documented in the request form. Other information that are needed are if there have been previous history or postcoital bleeding, and whatever information is needed that has to do with previous conditions of that patient. They should be well documented in the request form. If there is going to be error, the error will emanate from sampling error, transfer error after collection, and laboratory error. These are major causes of error, and we should ensure that no error is allowed at those points or processes of handling of those specimens. When there is improper collection of sample, I mean missing the area where the lesion really is, we can't get any quality smear. And where the smear is scanty, it wouldn't be satisfactory really. There must be cellular components. The sample must be rich in cells, squamous cells, then glandular cells. When sample is bloody, or the cells are traumatized, or the smear is full of inflammatory cells, they are not satisfactory and will not give us optimized screening result. Failure of lesion to exfoliate, despite correct technique, will lead to error. When the wrong layers of cells are transferred in smear, to lead to error. Then when you allow the smear to dry instead of fixing it immediately, is going to cause artifacts. And of course, if you don't fix properly, it's still going to cause fixation artifact. So all this must be taken into consideration while handling specimen for cytological diagnosis. Issues that revolves around laboratory failure. This includes poor quality smear, distorted cells through drying, and scanty cellular materials, which will not be really suitable for proper interpretation. All this may lead to misdiagnosis. Now, being done with the preparations of the patient and the laboratory, let's look at how to now collect this sample for cytological specimen. You are going to use the speculum to view the ectocervix through the vagina. And of course, with the end of the speculum, you insert the spatula into vagina area, and you press the tip against the ectocervix and rotate it 350 degrees in one direction. Then use a flat end of the spatula to sample if ectropion is present. Ectropion, this is when the uterus is invaginated. It is called ectropion. And instead of having the ectocervix, what you're actually having is the endocervix. So to avoid bleeding and injury to the very delicate endocervical cells, you have to use the flat end of your spatula. This is very, very important in sampling. Now, still on sampling, collection of specimen. To meet adequacy criteria, endocervical and ectocervical components should be present in the smear. Use the spatula first to avoid bleeding from the cytobrush. So use the spatula to collect ectocervical sample, and then use the the cytobrush to collect the endocervical cells. Endocervical cells deteriorate more than ectocervical cells. They are very, very delicate. So when you are using the cytobrush, rotate it slowly, a quarter or a half turn in one direction. Don't over-rotate, as this may lead to trapping of cells, which may make it untransferable, easily untransferable. So let's briefly look at tools, other tools that you can use for sampling. Iris spatula is one of them. Cyto brush, I've spoken about that. The cervix brush, I've mentioned them in my previous slide. clean grease-free glass slides, Cyto spray, if that's what you want to use to fix, or 95% alcohol for fixation, then you must have the speculum. For your iris spatula, it could be wooden or plastic. There is a flat end and a hollow end. The hollow end is rotated 360 degrees for sampling the ectocervix. You use a flat end for ectocervical sampling. I've said that earlier, when you have a tropium. When using the wooden spatula, make sure that the orientation is angular, maintain angular rotation. That's what I'm trying to show on this slide. We can't overflog the issue of appropriate collection of sample and its handling. So I'm going to take my time to talk about these tools and sampling. The Cyto brush as a tool now has a head made of brush and a narrow tail, which is the handle. It comes in different sizes, and it is used for sampling the endocervix. So this is for emphasis. You should know why you should use the the cervix brush and the Cyto brush for sampling. So don't forget, the cervix or Cyto brush is for your endocervical cells, while the spatula is for the ectocervical cells. You know, so when you collect this sample, quality-wise, the chances of having rich and satisfactory samples are increased, and it reduces the incidences of unsatisfactory smear. After collecting the sample, you have to spread it on a grease-free clean slide, and you move it backwards to have a well spread smear. I'm projecting that on this slide. You can see it. So using glass slide, your glass slide must be grease-free. It must have a frosted end where we can write the identity of your laboratory identity, the patient. Then you don't use ink for labeling. You can wash off during staining. Vial. Vial is used for liquid-based cytology. The Cyto brush or cervix brush is inserted into an opening on the lid to release the cells into the fixative containing vial. It is transported immediately to the cytology laboratory afterwards. The Cyto spray is another tool, but it is used for gluing pap smear specimen onto microscopic slides. The spray is a fine mist over cells that forms a tough pain barrier to preserve the cells when applied, and they come in different sizes. You choose or order for the size that you want. Cyto spray. Cyto spray should be applied immediately after smearing. The spray slide distance should be about 20 centimeters, and the spray should be for a few seconds. You spray for a few seconds to preserve the integrity of cells. The speculum as a tool for collection of specimen. The speculum has a mouth that enters the vagina to raise the labia and expose the cervix. The handle is preceded by a round outer part that makes the ectocervix visible for sampling. At the end of the day, when you transfer yourself, this is what you are going to have. So when you use a spatula, you see how you smear it on the same slide with the brush. No, don't forget to use the spatula, flat end for the ectocervical sample, and the brush for the endocervix. So this is how you spread it on the slide. And if you want to spread it one over the other, the spatula falls in the same direction, then the brush follows in the other direction. And these are, you'll see the third technique for brush, separately below and above it, you have the spatula. So you can use any of these smearing arrangements after you must have collected your specimen. Now, let's look at handling specimen for gynecological sample. Gynecological sample is either you take it from the vagina or you take it from the cervix. If you are taking smear from the vagina, it means your attention is focused on hormonal cytology. We'll be looking at that tomorrow. Hormonal cytology. If you are taking specimen from the cervix, then it is meant for detection of malignancy or cervical cancer. All right, so let's take a vaginal sampling now. Tools for vaginal aspirate. You can, when you are taking samples from the vagina, it could either be an aspirate or you scrape cells that are exfoliated in the vagina. One of the tools used is the needle and the syringe you are looking at in this slide, and a suction tube can be attached to it. When it is attached to it, with the aid of the speculum, the cervix is the vagina is opened, and then the exfoliated cell can be aspirated and it can be pulled or scraped onto the slide for smearing. Now you need 95% alcohol. This is very common. It's very important you know that. For wet fixing, you fix immediately. Then the syringe and the syringe is pre-attached with a vacuum aspirator. So as you pull the plunger, the trigger, is going to aspirate based on a principle of vacuum. The cyto spray, if you want to spray to fix, then of course the slide. You need all these tools for collection of vaginal sample. In resource-limited settings, you can have simpler ones, like the speculum, the forceps, the small syringes, and the rubber suction bulb to create pressure for aspirating vaginal samples. Making your vaginal smear. Vaginal smear should be immediately wet fixed 95% alcohol and stained with the pap staining technique. Duplicate smear should be dry fixed on the bench and stained with the Megrol or Leishman-Gimsa staining technique. Triplicate smear should be stained with the H&E technique. Pyramid smears should be stained with the sample as control. So you should be having up to 4 smears there. One for pap, one for Megrol, I mean the Romanowski stains now, one for H&E, then one for control. Stain slides should be validated and screened for malignancy. Then reported slides should be archived in the slide cabinet. I spoke about the squamous columnar junction earlier. So this is what it is. What you are seeing on your screen is the cervix and the different type of the cervix that matter in terms of cervical sample collection. You should understand what the transformation zone is, what the squamous columnar junction means, and of course what the transformation zone and the what we call the new squamous cell junction means. When you open the cervix, women who are of reproductive age, depending on the number of parity, number of children they have, the uterus moves after every childbirth. So when that happens, the cervix moves up. When it moves up, the squamous columnar junction changes position. The squamous columnar junction is a junction between the columnar epithelial cells and the squamous epithelial cells, stratified squamous epithelial cells of the ectocervix. So it moves after each bath. And as it does so, what it leaves behind is the transformation zone, where you now have the columnar cells transforming into stratified squamous cell. This is important. You can see the TZ on this slide. It is a transformation zone. The squamous, the columnar epithelial cells will more often than not soon become stratified. And at that zone, you have what is called metaplastic cells. Metaplastic cells are cells that have undergone a pressure, external pressure, and they try to cope with the environment and the stress they have been subjected to. So samples for cervical screening can be collected from there. And of course, the new squamous-columnar junction, where the tip of the speculum inserted will be. So the spatula can now be inserted and used to collect the sample. So this is to make myself clearer about you understanding the squamous-columnar junction, the transformation zone, and what I call the metaplastic cells. So this diagram gives you a better view of the transformation zone. You can see the dot arrow. The uterus will always move after each bath. So you have transformation zone. There you have metaplastic cells that have been really stressed. The squamous-columnar junction, where the speculum will be will rest, and the spatula will be able to reach the endocervix from the ectocervix. So the idea is actually that you have samples and cells from both the ectocervix and the endocervix. The ectocervical cells will be your squamous cells, while the endocervix will give you advantage to collect glandular cells, especially endocervical cells. So more on the transformation zone and squamous-columnar junction. The transformation zone is the zone where columnar epithelium transforms into squamous epithelium. It moves to the endocervix as new squamous-columnar junction. It breeds squamous metaplastic cells. I've said that before. So you collect samples from there, then you collect a sample from the transformation zone too. You read that up when you have your slide. Now let us move to non-gynecological smears, such as urine, CSF aspirate, effusion, sputum, and brush aspirate or sample. Urine. Urine samples received should be macroscopically described. It should be thereafter centrifuge for 5 to 10 minutes at between 1,500 revolution per minute to 2,000 RPM. The sediment should be smeared on albuminized grease-free, clean slides, and immediately wet fix in 95% alcohol. This is very important. Immediately wet fix. Then you can stain for purple stain, or you fix dry. You dry on the bench for the Romanowski stains, McGowan Gimsa or Leishman Gilter stain. After staining, the stain slide should be validated and screened for malignancy. Of course, you can later write your report to be sent. Types of urine sample. This categorization is very important for the sake of cellularity. Each of the types improves the quality of samples collected and the numbers of cells seen. The more cells you see in your sample, the better you'll be able to evaluate for malignancy. Voided urine, catheterized urine, ileocecal urine, cytoscopic urine, bladder irrigation and washing, cystic brushing. When it's a cysts they are always hypocellular, very scarce in cells. Brushing them during sampling increase the yield of cells for screening. Prostatic secretion, urine after prostate massage. Are we still together?
Yes.
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 Okay.
We are together.
The slides are not.
All right.
The screen is not showing. The slides are not following.
Yeah, I've noticed that from the end. I hope your Zoom link hasn't expired. Let me check.
I think it's from your end, sir.
Okay, I'm looking at it now. I think it's trying to come up now. I really want you to see the slide so I can carry you along. So we'll continue. Can you see the screen now?
Yes, sir.
Are you seeing?
Yes, sir.
Okay.
Yes, sir.
So
We can
we'll
see the screen now.
Yes, we can see.
So how do you handle the urine specimen? The urine specimen should be accompanied with the request form. Send fresh sample to the lab immediately, accompany it with request form, and the request form must contain patient identity and the clinician or physician's identity with the time, date, type of specimen, the nature of specimen, and of course, method of collection. That is voided urine or catheterized urine or ileocecal urine, etc., etc. The urine should be served if there is going to be 1 hour delay in a 70% ethanol. In preparing the patient should be with 1 glass of water every 15 to 20 minutes for 2 hours prior to collection of a sample. How do you process it? Fresh urine shouldn't last more than 1 to 3 hours. And immediately, if it's going to be more than that, it has to be refrigerated to preserve it. When it is more than 24 hours, it has to be fixed using equal volume of 2% carbo wax and 70% ethanol. It should be centrifuged to concentrate it. You can use centrifugation, method filtration, or cytocentrifugation, or liquid-based method to process the urine. Urine specimen will not be satisfactory and will be rejected if there's a delay more than 3 hours, 3 to 4 hours, and if it is not preserved in 70% ethanol. When the urine stays till the second day, it is no longer suitable for evaluation. So there's a device used to increase the yield for urine sample. It is called the cytoscope. This slide shows how it is used, inserted into the bladder to collect or aspirate urine. So we look at those specimen types, urine specimen types, one after the other, and see their peculiar characteristics. Voided urine, it should be collected between 3 to 4 hours after it has been, after the last void. Up to 100 to 300 ml should be collected. At the end of the day, the disadvantage is that the cellularity is sparse. The number of cells are not many. You'll find superficial cells there and intermediate cells. Most of the cells will have degenerated. Squamous cells are common. Then the trigon of the genitalia may become contaminated in women because you have to pass the tool through the trigon of the uterus to collect the sample. And of course, there could be inflammation or irritation of the organ. Non-cellular constituents such as crystals, casts, corporal amylacia may be present in that urine. Its best advantage is that it is non-invasive. It's non-invasive, no instrument. Catheterized urine. When the urine is catheterized urine, you find that it has moderate to highly cellular characteristics. What are the type of cells you see? You see superficial cells, intermediate cells, and basal cells. You will also, it suffers from poor preservation with pronounced degenerative changes if the samples are cooled. The urethra is not sampled in catheterized urine. Instruments used could cause artifacts. Urothelial clusters can make low-grade urothelial carcinoma. And see the slide I'm showing you. You can see those cells there. You can see the cellularity. The cells are more in catheterized urine. One of the disadvantages is that because it uses a catheter will be inserted in the bladder or the organ. There's a risk of infection. Ileal conduit specimen. Surveillance of cystectomy as when this with large amount of epithelial cells and the possible cells when this, and because of those debris, malignant cells may be obscured, and those are the things we are looking for. So that may increase the chances for error. Bladder washing. When that method is used, these are the cells you see. Ureter cell with the arrow. Find the columnar cells. See umbrella cell. What are the normal cells you can see in the urine? This slide is showing intermediate cells, basal cells. The cells may have high NC ratio, chromatin darker than superficial cells, the nuclei smaller than superficial cells, nuclear shape round, and even nuclear spacing. Okay, the umbrella cell. The umbrella cell has low nuclear cytoplasm ratio, a pale finely grounded chromatin, shown on this slide, a smooth nuclear shape, multinucleation is common, as you can see on the slide, and the cytoplasm is transparent. That's how you identify umbrella cells. We move to cerebrospinal fluid aspirates. CSF samples or aspirates like abdominal fluid, gastric fluid, bronchoalveolar lavage, pericardial fluid, peritoneal fluid, pleural fluid, etc. received should be macroscopically described. They should be thereafter centrifuged at between 1,500 to 2,000 revolutions per minute for 10 to 15 minutes. Sediments should be smeared on harmonized, grease-free, clean slides and wet fixed in 95% alcohol immediately for pap staining technique, or allowed to dry on the bench for the Megrod or Leishman-Gimsa stain. I mean the Romanowski now. Stain slides should be validated and screened for malignancy. Then reported slides should be archived after everything has been done in your safety cabinet or wherever you archive slides. Now, let's move to effusion. I'll take some time talking about effusion. Effusion will be defined as abnormal accumulation of body fluid, cavities, tissues, organ space. They are usually aspirated for psychological investigations.
What is it?
The fluid in the body normally has a balanced hydrostatic pressure. So this slide is showing the capillary with endothelial cells and the plasma proteins moving in it. When everything is balanced and in proportion, the colloid osmotic pressure is normal. And you do not have fluid, any fluid at all, accumulating in any tissue or any organ of the body. But when this dynamic changes, you can mute your mic. When this dynamic changes, There's, and for example, there's increased hydrostatic pressure as it happens in congestive heart failure. When the no obstruction, the dynamics. This will reduce the colored osmotic pressure and reduce the number of proteins, rate of protein synthesis. And of course, you find this happening in conditions like liver disease, where you have increased protein loss. And another kidney disease, there is reduced number of protein. When this happens, there is going to be leakages through the inter-endothelial cell spaces. That's what this diagram is showing. You see fluid, and when fluid leaks, you are going to have effusion. Exudate. As opposed to transudate, this is increase in plasma protein, and that forces a lot of pressure in between the endothelial cells, and it opens it wide. It opens it wide. So the number of effusion due to vasodilation is going to increase. It's going to increase. So you have exudate. These are the situations when you have effusion. So when you have effusion, naturally you'll be talking about edema. So I'm going to talk about pathogenesis of edema. Hydrostatic pressure. In congestive heart failure, there is constrictive pericarditis. So you will have edema, sodium and electrolyte imbalance during edema, albumin level, and water levels will change. There will be albumin loss, nephrotic syndrome will arise. You have liver disease, for example, cirrhosis. The other conditions like cancer, inflammatory scarring, or radiation defects. All this presents during edema. So what is the mechanism for edema? It is called by a mechanism that shifts the normal fluid balance of the plasma fluid and lymph flow. Movement of fluid controlled by opposing effect of hydrostatic pressure and colloid osmotic pressure. So there will be exit of fluid from an arterial end, which is balanced by inflow at venular end of microcirculation. And of course, more residual amount of excess interstitial fluid is drained through the lymphatics. When there is edema, you find these conditions, which I'm going to talk about one after the other. Increased capillary hydrostatic pressure. There's rise in hydrostatic pressure at the venular end of capillaries to a level more than plasma oncotic pressure.
Find
that there's minimal or no reabsorption of fluid at venular end. Number two, when you have reduced plasma osmotic pressure, there will be reduced albumin synthesis in liver, protein, there will be protein malnutrition. There will be fall in plasma oncotic, and when the net movement of fluid into interstitial tissues happen, you have edema. Number three, lymphatic obstruction. This happens through impaired lymphatic drainage, localized lymphedema, radical mastectomy for cancer, breast cancer, pressure on main lymph ducts, inflammation of lymphatics, occlusion of lymphatics by malignant cells, the Mirrois disease. This mirror lymphatic obstruction, you will have edema. Number four, sodium and water retention, hypovolemia. followed by renal vasoconstriction, where you have the renin-aldosterone mechanism working, the growth factor receptor, antidiuretic hormone, ability to reabsorb water. When all this lead to retention of sodium and water, you are going to have edema. And once there's edema, there will be effusion. That's where I'm going. Number 4, the glomerular filtration rate, when it is shifted, and when ADH function is dysfunctional, there's going to be change in dynamics. You have edema. When you have edema, you have effusion in your hands. This diagram just illustrates everything I have said. So, what are the samples we'll be talking about in effusion? We're talking about pleural, pericardium, peritoneum, and of course the cavities. We'll look at them. So effusion can be exudate or transudate. I've told you exudate when the protein level is very low, and transudate when it is high. So all these, the tables explain different conditions where you can have transudates and exudates. Most of it I had explained earlier. You can read it up, read more of it. I've spoken about congestive heart failure, etc. So this table wants to show us features of effusion, the appearance when you have a transudate, and you should be able to differentiate transudate from exudate when handling effusion. That's why this table is being projected for your rapt attention. Transudate is clear, but exudate is variable. There is fibrin clot in exudate, but it is absent in transudate. Cells you find in transudates are mesothelial cells, a few of them, but you have more of histiocytes and lymphocytes. In exudate, you have mesothelial cells, more of mesothelial cells, polymorphs, RBCs, red blood cells, eosinophils, and of course, you can have malignant cells. The specific gravity of transudate is less than 1.015. For exudate, the specific gravity is greater than 1.015. These are very important points you have to pay attention to. Protein content for transudate is less than 3 grams per DL and is greater than 3 grams per DL for exudate. Examples, causes of transudates or exudates in pleural effusion, left heart failure. For transudate, hypoproteinemia, constrictive pericarditis, hypothyroidism, and cirrhosis. All those are causes of transudate. Exudate, bacterial pneumonia, carcinoma, bronchial carcinoma, pulmonary infarction, tuberculosis, and connective tissue disease. So, body cavity now, where we can find effusion. Dorsal cavity is where bones of the cranial portion of the skull and vertebral column towards the dorsal posterior side of the body. You can't find effusion there. The cranial cavity, the brain, you can't find effusion. So these are sites and locations where effusion samples can be collected. Spinal portion, this contains the spinal cord, which is an extension of the brain. Ventral cavity, the anterior surface of torso divided by the diaphragm muscle into upper thoracic cavity and abdominal pelvic cavity. You can find effusion there. And you can aspirate it. Sites where you can collect effusion. The chest contains trachea, bronchi, lungs, esophagus, heart, and great blood vessels, thymus gland, lymph nodes, and nerves. Contains smaller activities. You can find effusion there. Pericardial cavity contains the heart, the pleural cavity surrounding both the pleural and pericardial cavities. You can find and collect effusion there. Abdominopelvic cavity, the imaginary line that runs across the hip bone, which divides the body into the abdominal and pelvic cavities. You can't find effusion collecting there, settling there. Abdominal cavity contains the stomach, liver, gallbladder, pancreas, spleen, kidney, the intestines, the ovaries, the peritoneal cavity, which surrounds the abdominal organ. You will get effusion there. And of course, the pelvic cavity, where you find the rectum, urinary bladder, and the uterus, etc. So in summary, when we are talking about effusion, these are the specimen types you will always find: pleural, peritoneal fluid or ascitic fluid, pericardial fluid, the pelvic washing, and peritoneal washing. So this slide shows the different colors that effusion presents when they are collected and what it indicates macroscopically. Chylothorax, you can see that's number one there, the color there. When that color is seen, it indicates chylothorax, something like oily sample. Number two, traumatic effusion. See, it is cloudy. Lymph, number three. See how it looks. The Rivalta test, number four, with black coloration. Feline infectious peritonitis. Number six, you see the color. Oh, not yellow, not chocolate. Can you see it now?
No, it has not changed.
No, sir. Yeah.
You should see it.
Yes.
Okay, so number six, you can see that color, ox blood color, pulmonary carcinoma. It gives an indication of a possible pulmonary carcinoma. And number seven, looking like chocolate, two, pulmonary carcinoma. And number eight, traumatic effusion. So those colors indicate different clinical conditions. So that's what this table has summarized. Different colors and what they are in transudate and the diseases that they indicate. So once effusion is collected, fluid up to 1,000 ml a liter should be transported to the laboratory. If a delay is expected, the specimen may be stored in a refrigerator at 4 degrees Celsius with the precaution of not allowing the specimen to freeze. So how do you now prepare your smear? It's either you use the squash method or the wedge method. For the squash method, smear a drop of albumin between 2 glass slides and separate the slides. Then place 2 to 4 drops of cell suspension on the abdominal surface of the bottom slide. Without applying pressure, pull the slides apart horizontally and immediately spray the cells and fix with aerosol. Allow it to dry. For the wedge method, which is shown on this slide, what you do is to fix it wet. The direct smear is immersed quickly in fixative, 95% ethanol. You can carry out the pap staining technique after saline rehydration, followed by fixatives such as 95% ethanol or 95% ethanol with 5% acetic acid. For Romanowski techniques, you are going to air dry the smear. The cellular material on the slide is allowed to dry completely. And of course, you can go ahead to apply the stains. Smear preparation optimization. How do you optimize effusion? To optimize the quality of samples and results, submit 2 or more smears of freshly collected fluid. These smears should be made from unconcentrated fluid, which is called direct smear, and concentrated smear, which is centrifuge smear. You make the smear from the sediment. You use the wedge technique for making smears of fluids of non-mucous samples. Samples like the peritoneal, the pericardial, and the pleural fluid. Use the wedge technique. Use the squash technique for mucoid or viscous fluid like the tracheal wash, joint fluid, and bile. Rapidly hydrate the smears. And once you hydrate them, they are ready for the Romanowski dye staining. The major cell you find in effusion are mesothelial cells. Those are the cells that they are the major cells in effusion. You have to look for them. This slide shows how mesothelial cells look like. They may be found singly. Most of the times, at 85% occurrence, they are found singly. And sometimes they could be found in small clusters, like stack of dishes, with slight molding, rollus formation. They occur in clusters. Some of them are like rosettes, your flowers, rosettes. They cluster around themselves like rosettes, and their size varies from 15 to 5 plus 5 to 20 or 10 micrometer. The shape is uniformly round or oval. That's how you identify mesothelial cells. The nucleus is dark purple. You can see it, dark purple. Same intensity. You see?
It's not showing, sir.
Cytoplasm. You said?
It's not showing.
So, okay. It should show now.
Okay.
Okay. So the
Lecture is
nucleus,
interesting, but for the fact that the slide is not moving according to what is being shown, what is being taught, we are not following it.
okay, I think it's the distance and the technology, how it is moving. You'll see it. Oh, can you see this one now?
Yes, sir.
Mesothelial cell.
Yeah,
I'm talking about mesothelial cell. I'm trying to describe it for you so that you understand the characteristic. So the nucleus is half the size of the cytoplasm. And of course, the nucleus is dark purple, as I've shown previously in that slide. The shape is central. The nucleus is centrally located. I've shown you that. I'll show it again because it's very important. Aha, you can see it. That's mesothelial cell. Mesothelial cell. Okay, can you see this slide too?
Yes, sir.
Yes.
Can you see this one I'm projecting? Okay.
Yes, sir.
So
Yes.
I'm still talking about the shape, characteristic, the features of mesothelial cells. So it's a major cell you find in effusion, and you must be able to identify them and know their characteristics. So when some of them form a cluster, as the red arrow indicates, it's called a pseudoecynous. that's what looks like a semi-rosette plus pseudosinus. You can see the nuclei showing some molding, internuclear molding. There is absence of common cell borders. They're always apart. They are apart. They like staying apart, staying singly. So their nuclear margins are irregular, as shown in this slide. And of course, there's what is called intercellular window, like slippers between two mesothelial cells. That's what this slide has projected. So when you see all this in a fusion, you'll be able to call it out. I hope I'm understood on that. Mesothelial cell. More mesothelial cells. This slide. Can you see this slide?
Yes, sir.
Yes.
Yes, sir.
Okay. All right, thank you.
Yes,
so I'm using it to reinforce everything I've said about mesothelial cells. So you can see the intercellular window, like
Yes,
slippers in between the two cells. Okay. Then you can see, in fact, it's all over. So when you see that, you know that the cell you are dealing with are mesothelial cells. They are mesothelial cells. They are mesothelial cells. Those are the major cells of effusion. Okay, let's go to respiratory cytology now. How you handle respiratory specimen. Examples of respiratory specimens are sputum, bronchial washing, bronchial brushing, bronchial alveolar lavage, and fine needle aspiration specimen, which can be used to aspirate a sample from the respiratory tract. Are you still seeing the slide I'm projecting?
Yes, sir.
Yes, we can see,
so
sir.
Two that you can
Yes.
do, you can use bronchoscope. You run a bronchoscope. It's a visual device, technological device that is run through the nostril into the trachea, down into the lower respiratory tract for sampling. And the objective is to have samples with high yield. The exfoliated cells are needed for evaluation. So this bronchoscope is that. Then the bronchial brush is inserted into the space to scrape the sample. How do you prepare specimen that you have collected? For bronchial washing, specimen are centrifuge and sediment smeared for Pap and Leishman-Gimsa stain, the Romanowski stain. If a delay is expected, specimen may be partially fixed in equal volume of 50% ethanol. Brushing specimen may be taken from any surface of the body. Or it is transported in the proprietary transport medium supplied by the manufacturer of the liquid-based systems. I'm going to talk about the liquid-based cytology later, so you see how it is done. Any added fixative should be noted on the request form. Direct smear, brush contents, brush tip may all be submitted as brushing cytology. Specimens are wet fixed. I've been repeating this. Specimens are wet fixed for Pap stains and dry fixed for Romanowski staining technique. This is very important. Sputum. Sputum specimen should be homogenized and smeared after description. It is wax fixed and stained with Pap method and dry fixed, stained with Leishman-Gimsa or Megrod-Gimsa stain, the Romanowski stains. A cell block preparation can be made to coagulate the sputum and concentrate it for higher cell yield. I'll talk about that later too, very soon. So staining techniques, what are these? After you have collected all these, your specimen, don't forget that we started from gynecological specimen, the vagina and the cervix. Now we went to non-gynecological specimen. There we talked about effusion, and we talked about urine, and we talked about respiratory samples. And I took my time to explain what effusion means, what samples you can get from effusion, the pericardial, peritoneum, cerebrospinal fluid specimen, the abdominal specimen, anywhere that fluid accumulates in body cavities, you can aspirate the fluid. Those are effusion. So after you have collected quality samples from them, and prepare them, how do you stain? So we are going to look at different techniques for staining. The first is perpendicular staining technique, which is a multi-staining technique, especially used in exfoliative cytology for both gynecological and non-gynecological smear. Smears are meant for pap stain are always wet fix immediately in 95% alcohol. The technique uses 3 cytoplasmic stains. This is very important for you. The EA5060, which stains superficial cells. You can be asked which stain of the perpendicular stains superficial cells is the EA50 or EA60 stain. The light green stains intermediate cells, while the OG6 stains keratinized cells. That's very important in perpendicular staining technique principle. Hematoxylin stains the nucleus. Critical stages of the perpendicular method include fixation, hydration, dehydration, and you have cytoplasmic staining, where the superficial cells must be stained. I told you superficial cells are stained by the eosinazole stain, EA50 or 60. Light green is stained by light green stains in intermediate cells, and the keratinized cells are stained by OG6. This is very important. You should understand this when handling perpendicular staining technique. So after staining, you can now dehydrate and clear and mount. So this is the protocol, standard protocol for staining. Standard protocol for staining. When you have the material, you go through that. Now, let's look at some Romanowski stains now. McGraw Giemsa. The reagents include Giemsa stock, and the Giemsa working solution. This working solution is diluted 1:10. And of course, is the working solution that is used for the staining. McGraw Giemsa is a Romanowski dye-based staining technique applied in exfoliative cytology. Smears are dry fixed in open air before the diluted stain is applied. The principle depends on using dyes with acidic and basic properties to stain cellular components. It is particularly recommended for differentiating blood cells. That's why Romanowski dyes are applied in cytology, is to differentiate blood cells, the polymorphs, the eosinophils, the granulocytes, and the non-granulocytes. Giemsa dye is a basic foundation of formulating this solution. So the standard protocol is what is projected here. We'll go through that later. Leishman, James's staining technique. This is another Romanowski dye-based staining technique applied in exfoliative cytology for staining smears. Smears are dry fixed in open air before the diluted stain is applied. The principle depends on using dyes with acidic and basic properties to stain cellular components. It is particularly recommended for differentiating blood cells. So any Romanowski dye is recommended for differentiating blood cells. This is a technique, standard technique for Leishman-Gimsa stain. The short staining technique. I'm walking you through staining technique you can apply both for gynecological and non-gynecological cytology. This short staining technique. This one is used for hormonal cytology, assessment of hormonal states in the female. Wet fixed smears are rapidly stained in short solution and dehydrated in increasing grades of alcohol. Short stain magnifies the eosinophilic staining of estrogen effects and cyanophilic staining of progesterone effects. Within minutes, the staining is completed, and you can find the result. The superficial cells, the conified cells, are stained brilliant orange red to show that there is a normal production of estrogen. When the cells are conified, it shows maturation. Then the non-conified cells are cyanophilic in color for their identification. Conified cells are distinctly demonstrated and distinguished from non-conified cells. That's what this slide is showing. I hope you can see the slide I'm projecting, the conified and non-conified cells.
Yes, sir.
Okay,
Yes, sir.
so that's the result you have from short stain for hormonal assessment. You'll learn more about that in my next lecture, when we'll be talking extensively on hormone assessment. Methylene blue staining technique. This is the staining technique for staining fresh sputum. If you want to quickly determine whether sputum sample is malignant or malignant cells in sputum, fresh sputum, it is methylene blue technique. It is a vital stain. It will stain those cells supravitally. So when you use methylene blue, which is a temporal staining preparation, what you do is to quickly suspend suspicious area or bloody part or purulent area of the sputum on a clean grease-free slide. Then you mix it and now apply a drop of methylene blue solution, 1%. You cover it with cover slip, then you can view it under the microscope. It's a very simple technique. This is what you will see as a result. Can you see this slide I'm projecting? Malignant cells using methylene blue. You can see they're
Yes,
large, calculated, you know. So there is an idea here that this sample is malignant. Then the specimen can be made, the sample can be made permanent, remove the cover slip, then fix it, then and process it accordingly for pap staining technique or Romanowski staining techniques. The point is, the objective have been realized, determining the presence of malignant cell in fresh sputum. So we'll move to the next staining technique, which is acridine orange. I'm going to project this soon. Okay, acridine orange is a fluorescent dye with capability to combine with DNA, deoxynucleic acid, and RNA to emit visible light. when excited by ultraviolet or blue light at wavelength 350 to 400 nanometers. So the result is what you are seeing on the slide: orange red, shining, fluorescent cells, which indicates malignancy or presence of genetic material, RNA, DNA. How do you differentiate between DNA and RNA? DNA emits green or greenish yellow light, while RNA emits orange red light. Malignant cells are rich in RNA, hence emit brilliant red, orange, or orange red light. Okay, now I spoke about cell block earlier on. I said I will show you more, talk more about it. So we are there now. When you have a fusion that is hypocellular, when the cell yield is not much, you have to do a cell block preparation. And cell block preparation is a concentration method that allows cytological specimens to be processed histologically, so that all the cells can come together. You can now see the arrangement of cells. You can use staining technique to highlight their nuclear features vis-a-vis the cytoplasmic features. Aspirates with scanty cells, tissue fragments, sediments, and blood clots are processed into paraffin blocks to provide further architectural information. That's what cell block preparation. Cell blocks are archivable. They are suitable for ancillary immunohistochemistry, immunophenotyping, and molecular. There will always be more. You are using cell block to optimize your sample. Aside the quality, you want to have from that small sample you have, you want to be able to do as many tests from it as possible. So aside staining for cytology, you are going to have block for histology. You are going to keep a slide there that can be sectioned for immunohistochemistry or for genetic testing or other molecular tests that may need to be done. This is what they call triaging. This one is called triage in a cytology test, optimizing the sample that you have. It is very important in targeted therapy and biobanking and precision medicine. This is what it is done. Supports patient safety practices of less invasiveness and mobilization of lesser material, so more can be done. That's what cell block is useful. So the technique is that you centrifuge specimen at 2000 RPM for 15 minutes. You add 2 drops of plasma to sediment it, and then thromboplastin to coagulate it. Turn the coagulated specimen into a filter paper and put in a well-labeled tissue cassette like histology samples. Then cover the tissue cassette and dip it into 10% neutral buffer from selection. Then process it as for histology, then to the section at 4 to 5 microns. There are different methods. Aside the plasma thrombin method, there is the fixed sediment method. For the fixed sediment method, you centrifuge at 2000 RPM for 15 minutes, add the fixative 10% neutral buffer depth, malonyl or alcoholic pricklic acid, then allow it to stand for 2 hours, separate the supernatant and discard it. You're now adding the sediment with agar or gelatin. Everything is about concentration. Find the method to concentrate it. Turn it into filter paper, wrap it and fix in 10% neutral buffer formalin and process as for histology. So for the plasma thrombin method, this is what you see. This slide I'm projecting for you to understand better what I've talked about. So you see, that's the effusion. It is hypocellular, so it will be centrifuged rapidly at high speed. Sometimes cryocentrifugation to concentrate it, then separate the supernatant, the sediment, and of course the canned supernatant, and you now add the plasma and thrombin to solidify, make it semi-solid. You can now put it into cassette feeds and process as for histology. You have your cell block, and this is the result you have from the cell block. You can see it looks like histology. That's what you'll find. Cells well concentrated, and the arrangement clearly seen. The cellular arrangement clearly seen, made up. So anyone seeing this will have an opinion, an informed opinion about the cells that are being demonstrated. For me, this can't be less than an adenocarcinoma. Okay, liquid-based cytology now, still on techniques. Liquid-based cytology is a concentration method for preparing specimen for cytological staining. It's a technique for acellular smears that are very few. You have to maximize what you have. Technology has made that possible. So they are centrifuged at high speed onto slide. And of course, the slides are very clean. It's not like that traditional PAP method that always have a dirty background. This one, always very clean, always very clean. Justification for liquid-based cytology. Liquid-based technique is attractive for the following reasons. Number one, there have been a prolonged, persistent disadvantage of the traditional PAP method, whereby 55% of the results are found to be false negative, and very difficult to interpret. 6.4% of the report from traditional PAP are ambiguous. Experts can't make any good deduction from it. 9.7% are inadequate specimens. So when liquid-based cytology is applied, there's improvement on conventional PAP. There is modernization of technique. And of course, it is good for small and acellular samples. It reduces the number of inadequate snaps. So these are good justifications where by liquid-based cytology will be applied. And more justifications. There is high sensitivity in detecting cervical intraepithelial neoplasms or lesions. LBC is a very good technique to make that happen. Cells are well preserved. It's very good for fluid samples. It is the primary method for detecting cervical intraepithelial or fibroid. Then more tests can be carried out. PV, molecular testing, chlamydia, diphtheria, gonorrhea, can keep more samples for microbiology investigation. In liquid-based cytology after sample collection, the brush is first removed into a vial with a preservative and then transported to the laboratory. In the laboratory, a uniform layer of cell is prepared on the slide. It is thought that this method of cell transfer, which I'm going to show you between the two types of LBC techniques, short part and team prep, I'll show you, they result in a better representation of the entire sample as compared to conventional PAP. The types of liquid-based methods, the team prep or the short part, or I will say, and short part. So let's go through them one by one. If you are asked to write short notes or on a liquid-based cytology, the justification I've spoken about is important. You look at the types, which is team prep and short part. The team prep now. The team prep LBC, here, cervical specimen is collected using a cervix brush. I told you how to use cervix brush to collect a cervical sample or cytology sample earlier on this lecture. The brush is rinsed in a vial with methanol-based preservative fluid. That's what you see. You can see the slide. That's a tool for your LBC, thin prep. The vial is supplied by commercial vendors. Well, you can devise a local one that can look like that. Cells are released. This slide shows how cells are released by pushing the brush to the bottom, forcing the bristle of the brush to tear apart and swirling the brush into the fluid, the fixing fluid. Subsequently, the brush is discarded. When they are transported to the laboratory, cells are isolated from the fluid by vacuum filtration and transferred to the slide using air pressure for adherence to stick the sample to the slide. So this is what this diagram is showing. This is the workflow for thin prep. You centrifuge highly, discard supernatant, fix it, then transfer it to the slide. At the end of the day, you can see the thin prep preparation. The slide preparation is very thin. It's very thin and clear, not like the conventional pack. And the samples, the remnants, you add histogel to it to make it like a cell block. You cannot do cell block from it. So you have extra sediments to use for cell block and other ancillary testing. The second liquid-based cytology method is SurePath. SurePath works on the principle of density gradient sedimentation. The cervex brush is dipped into the specimen vial after collecting the sample. So you can see it. That's how the specimen vial looks like for SurePath. So once it's that, it will be removed. Then the specimen now, in the specimen vial, you transfer it to vortex, where you shake it at a very high speed to concentrate the sample and separate the mucoid from the denser cells. High-speed vortex is meant to break the mucus and large cell groups, and then is treated through a density gradient centrifuge process, which remove blood and debris. So after that, you have cell pellets, which you now resuspend. You allow it to sediment onto a glass as a spot. So instead of being spread thin, this one will be a spot on the slide. That's why it is SurePath. The concentrated sample on glass slide is stained as requested with H&E, PAP staining technique, and you can see the spot there. That's SurePath. So when you see the slide, you'll be able to determine whether it's SurePath or thin prep. Okay, so let's go to, after applying the techniques, what do you see? So look at this slide. It's showing the result from, you can see how clean, very clean, and the cells are very, very clear, clearly seen. So the nucleus, the cytoplasm, the intracellular materials or milieu, everything is seen very, very clearly. So that's what makes it different from the conventional path, where your background is dirty, or full of debris. The technique is highly sensitive and specific for detecting high-grade. You can see the reason. Look at the clarity. That's why it's very highly sensitive for detecting high-grade lesion. You cannot miss it. Once you know it, you can't miss it. Can't miss. So I'm going to show you some of the reporting, how to identify cells now. Once you have prepared, then you should be able to make diagnosis. Reporting of cytological smear. So I'll take you through the basics of reporting cytology smear. Can you see my screen?
Yes, sir.
Yes, sir.
Yes, sir.
Yes.
Yes, sir.
Reporting of cytological smear. When you have a cytological smear that have been stained before you, there are questions that need to be resolved. And the two major questions are always, is it benign? Is it malignant? That's the most difficult question you can resolve. Once you can resolve that, others will follow. So if it is benign, how benign? Is it a low squamous intraepithelial lesion? Question, keep asking questions. What are the features? So that's what this slide is showing. If it is benign, you are saying it's benign. Okay, the cell that I'm projecting has large nuclear pallor, nuclear halo. The nucleus is granular. And when that kind of a cell is seen in a smear, it's called a coelocyte. It's called a coelocyte. A coelocyte indicates a benign condition, a low squamous intraepithelial lesion, which needs to be followed up clinically so that it doesn't over time transform into a malignant condition. The second one projected on this slide, I always call this structural defect fibrous cells. Structural defect fibrous cells. You can see they are long, central, small nuclei. It's not big, not bigger, you can see, relative to the cytoplasm. So it's not malignant. It's just that there are some abnormal things happening in there, whether in the uterus or the fallopian tube or the vagina. So it's a structural defect being seen. So what one can make from this slide is that it is atypical. It is atypical. The structure is not normal. It's not round. It's not oval. It's not long, tabular like columnar cells. It looks more like fibrous cells. So cells like this are they are benign. They are benign. So it's benign. So that can be concluded. It's benign. And that could be reported. Aside benign, is it malignant? If it is malignant, if what you are looking at is malignant, then more question. Is it high seal? High seal means high squamous intraepithelial lesion. Is it high seal? Is it AGC? AGC means atypical glandular cells. Is it atypical glandular cells? Or is it outright squamous cell carcinoma, SCC? And if that's what we are looking at, what makes it malignant? What are the features? So I'm going to walk you through some criteria, basic criteria for malignancy. So you'll be able to make a final decision on the malignancy and the type of malignant cells you are seeing. So criteria for malignancy now. This slide is showing cells with large nucleus, big nucleus with high nucleus cytoplasm ratio. The nucleus are dense, they are hyperchromatic. So these are classical features of malignancy. Marked pleomorphism, the sizes of the cells are different, small, big, intermediate, they are of different sizes and shapes. So a smear with this kind of feature is malignant. It's malignant. And that's a high squamous intraepithelial lesion by standard conventional reporting system. Now, once you are done with the nucleus, now we have to talk about cell arrangement. That's another condition for determining whether a cell is malignant or not. So such criteria or arrangements include acinar arrangements. Acinar arrangements, like pancreatic cells. round clusters of cell, circular form. When you look at your grapes, how they are arranged, that's rosette. Some in sheets, like the honeycomb. Some are arranged they are tall, and they show angularity. North pole, south pole, extension, that's angularity. They are tall. It's a feature of malignancy. They are clustering. Some are in 3D clusters. Those are malignant cases. Once they are arranged that way, it's easy to conclude that they are malignant. So if it is malignant, it's tall, angular, well, AIS can be in the picture. Adenocarcinoma in situ, AIS. More on the arrangement of cell. Sometimes the cells doesn't cluster. They occur singly, alone, but delicate and dangerous. One man riot squad. Look at this slide I'm projecting. A single cell, but it is dense, dark, hyperchromatic, high nuclear cytoplasm ratio, irregular nuclear membrane. Those are features of malignancies. Cells like this are called litigation cells. An untrained eye will miss it. Untrained mind will miss it. So I call it benign because it's malignant, highly dangerous, highly malignant. It's an immature cell. And you can see the chromatin is coarse, regular membrane. Those are classical criteria for malignancy. Sometimes you see those 3 cells there gathering, clustering together. They are very dangerous cells. Big, bigger, biggest. That's a pattern of malignancy. It's malignant. And see the nucleus large, dense, hyperchromatic. One can conclude that this is a high seal too, malignant condition. More on cellular arrangements. Cell can be in crowded form, crowded arrangement, crowded form, like this slide I'm projecting. Crowded cells. Crowded cells. Deep dark, hyperchromatic, different sizes, which are extreme sizes and different shapes. It's high seal. It's a high squamous interepithelial lesion. More on arrangement. Sometimes they are in what is called 3D arrangement. Anywhere you adjust the coarse adjustment on your microscope, you see cells in all the dimensions. That's 3D arrangement. Clusters like that, they are high squamous interepithelial lesion and they are glandular. So it's an adenocarcinoma. Adenocarcinoma. So as I'm talking about this criteria, your mind should be directed at the different criteria one can use to conclude that a case is malignant. Sometimes, as this slide shows, the arrangement neighborliness is loose clusters of cells, as is shown here. Squamous cells that, they are together, but they are not together strongly. They are loose with distinct community borders. Distinct community borders. You can actually, an ant can walk through them, those spaces. Some of the cells are eosinophilic. That's the beauty in your one of your pap stem we spoke about. OG6. You can see keratosis, smudge, dense nuclei, and keratinization. So the arrow is pointing at what I'm describing. So those are features, classical features of malignancy. Okay, so now, what's the nature of nuclear chromatin? Let's go there. We have considered the cell, the size, shape. We have considered the arrangement. Now let's consider the chromatin, nuclear chromatin itself. Features of malignancy: is it granular? Is it coarse? Is it clumpy? Are they in clumps? So this slide is trying to show you what those terminologies means and when they come into play. Clumps of chromatin is a feature of malignancy, high C. The other one is granular chromatin. Is high C, malignant. And when it is coarse, you can see deeply granular, coarse chromatin. It's showing different levels of malignancy. When it is clumpy, it is mild, high C. Granular is moderate. But when it is coarse, that's high level. And that one, it could be that the tumor has already invaded other adjoining organs. Could have features of invasion. Now, being done with the reporting of either benign or malignant, let's look at, well, if those situation doesn't exist, is it infection? Okay, so if it is infection, what are we looking at? If it is infection, what are we looking at? So the slide before you after staining could just be infectious cases. Okay, we'll look at some infectious organism, bacteria, actinomyces. Actinomyces are thread-like filamentous bacteria that occur, can see in cytological smear. This is cotton ball. It's called cotton ball. It looks like cotton wool. When you see that, that is a bacteria infection, actinomyces. Then Leptotrix, that's a long filamentous fungi. Okay.
Right.
Can you see this one? Leptotrix.
Yes.
Long filamentous fungi associated with Trichomonas vaginalis, like spaghetti and meatball. When you see Leptotrix, you start to have to look for Trichomonas on the same smear. You will find it. It's a bacteria, it's microbial infection. Okay, let me talk about more on infection, bacteria infection now. Cocobacilli, clue cells. It's a bacterial infection. You can find it in smears, cytology smears. It's infection. That's Gardnerella vaginalis. No. Shish kebabs, Candida albicans. You see the hyphae, the spore, no, arrangement, how they cluster, tie themselves around the squamous cells, they have colonized the squamous cells, eating it up. So that's infection. What type of infection? Let's look at more. Cryptococcus, it's a fungal infection. Paired cell, they are paired cells, refractile and with different sizes. The upper one is called teardrop appendage. Teardrop appendage. Like you want to drop a drop of a normal saline on your slide. So the way it will fall, that's teardrop. Blastosis is another fungal infection. Sometimes it is confused with Cryptococcus by untrained minds. So, but you can see, yes, the cells are double cells, doubly refractile with capsules, thick capsules, but the appendage is almost like the same size with the mother cell. So mother and daughter, it's a burden of cells, but the size seems similar. That's blastomyces. That's what is used to identify blastomyces and distinguish it from cryptococcus. Those are exam questions. Okay, let's talk more on microorganism infection. Fungi, histoplasma. This is what you see. You see how those cells colonize the, they have eaten up almost all the squamous cells there. And you see how they cluster. And of course, I call this a battleground, always a battleground. You see debris, remnant of war. You see these histiocytes have been mobilized there, connective tissue, so there's what I call guards. No, they are there now, fighting, trying to deal with the bacteria, the fungi there. And that's what you see, those granular features you see, they are histiocytes, multinucleated large cells. So that's synonymous with histoplasma fungal infection. That is still site with intracytoplasmic and intranuclear granules. Okay, more, is it infectious? Protozoa, Trichomonas vaginalis, they are oval. You can see the arrow pointing, the small arrow pointing at those cells, oval cells with small peripheral nuclei. Those are Trichomonas vaginalis. They are always not very far from the squamous cells they want to infect and eat up. Their target is always to eat up the squamous cells. More, is it chronic infection? Is chronic infection, then we are talking about follicular cervicitis, where you have large histiocytes, connective tissue histiocytes mobilized to that site and start swallowing the foreign bodies, the infection, the bacteria or the fungi. So, and they take up stains. They take up the stain because they are live. So that's why they are called tangible bodies. Histiocytes with a drop of stains. They have taken up the stains. They are macrophages, connected to the macrophages. And all around that smear, what you are seeing, those small and big round oval cells, those are lymphocytes, large, small lymphocytes. They are typical of chronic infection. Chronic infection. Now, if alternatively is the polymorphs that dominates the picture, as you are seeing the other picture, those are just simple acute infection, cervicitis. So if you are not dealing with a benign condition, you are not dealing with a malignant condition, you are likely dealing with infection. So, and we are looking at different types. Is it bacteria? Is it fungi? Is it protozoa? Then is it viral? So for viruses, you see HSV, herpes simplex virus. Herpes simplex virus. Herpes simplex virus. The characteristic cytological feature for this, you should know, is molding, MMM, molding, margination, multinucleation, the 3 M's. So that's where the arrow points at. Molding, margination, multinucleation. If it is not HSV, it could be HPV, human papilloma virus. The cytopathic effect is what is seen in this slide. Coelocytes, squamous cell with a large nuclear halo, and of course granular nucleus. So it typifies viral infection. more on infection. Is it adenovirus? With adenovirus, this is what you see, small cell, calcium-leading cells with nuclear halo, intracytoplasmic, nuclear inclusion bodies, granular material, smudge cells that are dense. It typifies adenovirus. Then cytomegalovirus, CMV. That one looks like an owl's eye. Look at it jumping at your owl's eye with intranuclear, intracytoplasmic inclusion bodies. When that is seen, that's cytomegalovirus. Okay, so if it's not chronic or acute infection or viral infection, is it inflammation? Is it inflammation? So if it is inflammation, you have a period of healing where you have a reactive cells, as it is shown in this slide. The cells are large, they have prominent nucleoli, the cytoplasm are pale staining, but there are distinct intercellular borders. And man can walk through those bridges, cellular borders or intercellular bridges. That's reactive change. It is not malignant. Of course, it's just a healing process. Tissue repair, reactive changes. Maybe there's an infection somewhere, whether bacteria or fungal, that has been resolved, and the cells are healing. That's when you see features like this. Okay, they're multinucleated giant cell, histiocytes. You can see the cell has ingested many foreign bodies. And of course, other cells too, fellow smaller histiocyte, multinucleated giant cell. It typifies chronic infection, chronic inflammation. Okay, now finally, let's look at Barr bodies. Barr bodies are the inactivated condensed chromosomes that occur in female to silence one of the X chromosome in the squamous cells. It's only one chromosome, X chromosome, that should be noticed in the cells of females. One has to inactivate the other and make it silence. So the silenced one is one that now clump. It's a chromatin dot that is seen as Barr body. It is meant to indicate the silenced X chromosome. And that's why it is used in the identification of the female sex cell. XS. So you see just one Barr body X. They are a powerful tool for sex determination and, of course, for forensic investigation. When people commit crimes and you cannot decipher the sex because the criminal has escaped, but you have the sample, you can use Barr body to determine whether this is a female or a male. Characteristically, Barr body occur as nuclear appendage in buccal smears, 20 to 30% of cell from female, and they also exist as drumstick lobes of neutrophils in romanostic saints. When Barr body is present, it indicates that the individual has more than one X chromosome, and if none, it indicates the individual has just one X chromosome. So this diagram is showing you how it looks like. Barr body, nuclear appendage. If you see one Barr body, that is a female XS. If there is none, it is male XY. How to collect specimen for Barr body? Mouth, you collect the smell from the mouth. Mouth should be rinsed with clean water or normal saline to remove particulate matter. Scrape the buccal cavity with round end of iris spatula. Make your smear on a clean green film slide. Fix it immediately in 95% alcohol. For what technique now? Pap stain. Then you can dry fix or Romanowski. So why should you do bar body tests? So these are the clinical application of bar body now. For sex determination, when the genitalia is ambiguous, the clinician cannot decipher whether it is male or female. Bar body must be investigated. 2, Klinefelter syndrome, chromosome number 47, 47 numbers of chromosome, XSY, phenotypically male. And you want to confirm that, you have to investigate the buccal smear. Turner syndrome, when there's just no Y chromosome, just X, phenotypical female. Typical female, but there's confusion. You may have some characteristics of male, and the number of chromosome is 45. Then the superwoman. These are clinical application of a bar body investigation. You should be able to talk about this. Okay. Now, how do you stain them? The techniques now for staining bar bodies. Cressil fast violet method. As usually, after collecting the samples, wet fix in 95% alcohol for 30 minutes, transfer to 50% alcohol, few seconds, rinse in distilled water, stain with Cressil fast violet acetate solution for 5 minutes, rinse briefly in tap water. You dehydrate, clear, and mount. So what will you see? Let's look at what to see using, there are other staining techniques, but Cressil fast violet is a classical technique that reveal perinuclear dots, bar body distinctly. So the techniques for bar bodies, you can use H&E method to demonstrate bar body. That's what this slide is showing. It's very fuzzy, but it is there. You can use pap stain. It's very, very fuzzy there. Not as you'll find in Cressil fast violet. You can use aceto or same method. You can see that perinuclear dot there. And for Cressil fast, you can see how that purple pointed dot is. It shows bar body distinctly. That's one of its advantage, and that's why it is used routinely. Other method, aceto or same Cressil acetate fast violet. That's one to combine the advantages of a same method and Cressil fast violet method. And finally, you have Romanowski stain, Leishman stain, or Grunwald. It will demonstrate bar body in neutrophils as a drumstick. That's what this slide has shown. So, in summary, we have looked at medical cytology today, starting from a non-gynecological and gynecological smear, cervix, vagina, and we went to the other samples you can use, urine, respiratory specimen, effusion, all types of specimen, and I had distinguished transudates and exudates. I've shown you what type of cells you see, how to report, a basic way of reporting cytological smears, that is benign or malignant or infectious. If it is infectious, what do you see? What are the criteria? So understand those basic things, you'll be good to go in a clinical cytology. So we are rounding up the lecture. For your assessment, I understand that we have to do CA for you. So I will be using attendance lecture, group assignment. After my lecture tomorrow, I'm going to give assignments. The students in the class will be grouped. So through your class rep, I'm going to send the assignment, which will be submitted in 2 weeks. So we use that to assess your continuous assessment. Then maybe next month during the exam, we'll get some very simple questions that we can answer. So thank you for coming today. Tomorrow is another day. If you have questions for me or comments, you can make it in 1 to 2 minutes. Thank you.
Thank you.
Wow.
Thank you, sir.
Thank you very much.
Class rep, please, you send the attendance of today to me.
Thank you, sir.
All right, you are welcome. Class rep, please, you send the attendance of today to me. So tomorrow, our second and final lecture will go tomorrow. Thank you. God bless you.
Well done.
Amen.
I appreciate it.
Thank you very much.
Amen. Thank you so much, sir.
You're all right.
Sir.
Sure.
Oh, that.
You enjoyed the lecture. So tomorrow will be better. Thank you. Have a blessed night.